Thank you very much, Jess. And thank you for the invitation to give this talk. We're now shifting from prevention to diagnostics. I'll be talking to you about new technologies for hepatitis B quantification and monitoring with a special focus on correlated antigen point-of-care tests. These are my disclosures. So to set the scene, I will use prevention of new hepatitis B infections as the the basis to justify why hepatitis B quantification is integral in recommendations. Since 1992, the WHO recommendations for preventing new hepatitis B infections have focused on vaccination, initially on infant vaccinations, and in 2009, with the introduction of the birth dose recommendations. And in 2020, the first WHO guidelines, specifically for prevention of hepatitis B mother-to-child transmission, recommended antiviral prophylaxis during pregnancy for all pregnant women with a viral load more than 200,000 IU per ml. In the absence of hepatitis B DNA viral load quantification, E antigen can be used as a proxy, and women who are E antigen positive can be started on prophylaxis during pregnancy. There was very good data to show that at this threshold, we can curb most of the mother-child transmission rates if this is coupled with previously existing guidelines that are the birth dose and the infant vaccination. However, given the logistical challenges of having access to both hepatitis B DNA viral quantification and E antigen testing, the WHO 2024 recommendations added a conditional recommendation without much evidence to back this, to say that if there is limited access to hepatitis B DNA and E antigen testing, we can consider providing prophylaxis for all pregnant women who are surface antigen positive. Now, we looked at the data, the proportion of pregnant women who actually have high viral load or antigen positive, and we found that globally, only about 15% of pregnant women would be either have a viral more than 200,000 or an E antigen positive. And this means that the vast majority of pregnant women actually had low hepatitis B DNA viral load levels and negative E antigen. So doing a test and prophylaxis all would be putting 85% of women on prophylaxis when they don't really need it. But what options do we have? Can we really overcome this barrier for the lack of diagnostics? Previous systematic review and meta-analysis had looked at the pool performance of E antigen to diagnose women who had a viral load more than 200,000. Most of these studies were done in Asia, with only 2 of them from Africa. But we found that E antigen is actually a very good proxy of viral load in pregnant women. However, most of these studies use lab-based immunoassays, which are not routinely available in low and middle income countries. So E antigen, although can be used as a proxy for viral load, it still has the same barriers. In some settings, it's even less accessible compared to hepatitis B DNA viral load. There were a few studies, 2 to be specific, included in this meta-analysis and systematic review that looked at point-of-care E antigen testing. And what they found was that sensitivity and specificity were significantly low, that it was not a reliable marker to identify pregnant women who are E antigen positive to use this for prophylaxis initiation. And then Yusuke Shimakawa and Abdoulaye Seck from Institut Pasteur Dakar did a study in Senegal where they looked at the specificity and sensitivity of E antigen detection using point-of-care E antigen test, which can be deployed in the field. What was found that in all the 3 point-of-care tests that were used, the specificity and sensitivity were very low, with BioLine being at 31% of specificity, Insight at 42%, and OneStep at 29.8%. So again, E antigen test can be used, but the point-of-care diagnostics that were commercially available had very low levels of sensitivity that makes their use in clinical diagnosis challenging. Hepatitis B correlated antigen is a novel serum biomarker that has been shown to correlate very well with hepatitis B DNA viral load. So it is a composite marker that includes 3 hepatitis B-related proteins, the core antigen, the E antigen, and the P22CR. All of these share a common amino acid sequence, and they're derived from the pre-core and core regions of the hepatitis B genome. They have been shown that core antigen has a very good correlation with intrahepatic cccDNA, intrahepatic total hepatitis B in the liver, and serum hepatitis B DNA. And to a lesser extent, it correlates also with quantitative surface antigen in serum. The challenge is it remains detectable in low hepatitis B DNAs and even after surface antigen loss, so it's not a reliable marker of treatment response, but as a marker to initiate treatment or prophylaxis, it showed very strong correlation with these clinical biomarkers. Again, Yusuke and Yoshida did a study where they looked at the correlation of hepatitis B DNA with cccDNA across different hepatitis B genotypes, which are known to be circulating in different regions of the world with hepatitis B endemicity, and they found good correlation across all hepatitis B genotypes with very high level of sensitivity and specificity, especially to identify individuals with hepatitis B DNA more than 200,000. But initially, core antigen was also a lab-based assay with equipment and instruments and laboratory personnel and qualifications required. So the next step was to develop this as a point-of-care diagnostic tool. So the EPS-line HB core antigen rapid diagnostic test was introduced a couple of years ago, and the test can be deployed in the field and requires a series of tests, a series of steps that starts with a finger prick blood collection with a few drops put into a pre-treatment solution mixed in the field and then added onto a cassette, with results usually being available from sample collection to availability of results within 45 minutes. Following the availability of this point-of-care RDT, we did a series of studies in Africa and in Asia to look at the performance of core antigen RDT to identify individuals with hepatitis B DNA above 200,000. And in almost all of the studies, we found that it had a very good sensitivity and specificity. What was especially interesting was that we found very good performance of the core antigen RDT across different sample types. So with fresh and stored serum, with dried blood spot samples, with capillary blood, and with plasma as well. Further, a proof of concept study was done in Kilifi by Philippa Matthews and her group there, where they looked at the correlation of hepatitis B, core antigen RDT correlation with liver fibrosis markers, with elevated ALT, high APRI score, and elevated FibroScan. And they found that in addition to identifying individuals with high levels of viral load, core antigen RDT can also identify individuals with elevated ALTs, raised APRI score, and high FibroScan. So this means that it has some promise in identifying individuals who would be eligible for antiviral therapy beyond just prophylaxis in pregnant women. So in short, the core antigen RDT can work across sample types, including dried blood spot, which is very ideal in the field. It completely eliminates and bypasses the need for electricity, as it's all kind of like purely a field implementation gadget. Results are relatively rapid, and the price has consistently come down, initially from $15 to now a promised marketing price of $5 US per test from the manufacturers. It's one thing to have a relatively low selling price, but at the end of the day, the test would need to be affordable for the programs that would most likely need it. So we looked at the microcosting and the cost effectiveness of using core antigen RDT, specifically targeting its use for prophylaxis in pregnant women initially. And we found that even comparing different scenarios, in one where we're doing systematically hepatitis B DNA viral load by conventional methods, doing e-antigen testing usually by serology, doing the core antigen RDT, or a treat-all scenario where we're doing the WHO 2024 recommendations of test and prophylax all, hepatitis B core antigen tended to be more cost-effective than these other three scenarios. And most of the cost savings were in the proportion of individuals who would need to be tested after you've eliminated the additional cost of actually identifying the few individuals who needed the prophylaxis. The other thing that we wanted to look at for the core antigen test was its environmental friendliness. We know that globally 4% of all carbon emissions are now due to healthcare product waste management. So we want a test that can be easily deployed in the field, that is cost effective, that is affordable, but it also needs to be friendly on the environment. So in this study that was done by a master student that we had in the MRC unit, the Gambia, we aim to evaluate and compare the carbon emissions from core antigen RDT compared to conventional PCR for hepatitis B DNA quantification. And we only looked at the last mile of using the core antigen RDT from after it's been produced. So the transportation into the country, into the, up to the health facilities, the product use at the study sites, and then the waste and end-of-life management of these RDT kits. And in summary, what we found was that core antigen RDT had but 30% carbon emissions from the core antigen RDT were a third compared to conventional RDTs, and most of the carbon emission savings were around the energy consumption required to do hepatitis B quantification and the travel time of patients to go back to the clinical sites to initiate treatment, given that most of the time when we use the PCR-based viral loads or even the gene expert, results are usually not available and patients would have to make a second trip to the clinic to get their results done. So moving forward, we decided to look at the field implementation of core antigen RDT, the usability of users in the field, how easy it is to use, and what is the performance of this. So we implemented this in an ongoing study in the Gambia and Burkina Faso, where pregnant women are systematically being assessed for eligibility for hepatitis B prophylaxis. And these results were for the first 7,000 women enrolled in the Gambia, of which about 177 were hepatitis B surface antigen positive. Amongst these, we systematically measured hepatitis B DNA in all of them and found that about 7% had a hepatitis B DNA viral load above 200,000. We found 90% sensitivity and 97% specificity of core antigen with viral load when we used plasma, and similar levels of sensitivity and specificity when we used it with capillary blood, that is finger prick blood. So the next step for the use of core antigen RDT now is a study that we are rolling out through Core Hep B that John presented to you yesterday, where we are scaling up the use of this RDT at a national level in the Gambia to look at the issues beyond just the performance, like how can this be implemented into routine care in antenatal settings as a tool for eliminating mother-child transmission. And what we are doing in the Gambia is to evaluate a decentralized strategy for prevention of hepatitis B mother-child transmission using RDT core antigen in rural settings where it would otherwise be impossible to identify women with a high viral load. We are looking at the real-world implication of this strategy that will be led by the Ministry of Health, and we will assess feasibility, program impact, acceptability of both health workers and pregnant women, and cost effectiveness. And a similar study that will be led by Yusuke Shimakawa, and that will be done in Cameroon, Cote d'Ivoire, Togo, and Vietnam, will evaluate whether a targeted strategy using this RDT core antigen is non-inferior compared to a universal test and prophylax all pregnant women for prevention of mother-child transmission. We are working with Fujirebio, and by we I mean Core Hep B, to develop a second generation of the core antigen RDT, which is aimed at identifying individuals with a much lower hepatitis B DNA viral load levels of 2,000, which is what is recommended for initiating antiviral therapy in adults. And for this, we are developing a study in the Gambia, Ethiopia, and Malawi with collaboration with Kumamoto University in Japan and Fujirebio, which is the manufacturing company, to develop simplified delivery models of care for hepatitis B based entirely on point-of-care diagnostics, in which we would implement this second-generation core antigen RDT plus an ALT point-of-care test that you will hear about shortly from Haiti. And we hope that together the first and second generation additives together can both scale up hepatitis B, PMTCT service in low and middle income countries, but also simplify the decentralization of hepatitis B care down to primary care levels where laboratory services for DNA quantification might not be available. And with that, I conclude my talk. I'll put up these slides here for a multiplex survey that we are currently doing in collaboration with the WHO to understand preferences around multiplex testing for hepatitis. So we'll be grateful if you can complete these surveys as providers and share this within your networks. Thank you very much.